Hi, this is Jeff Lighthall from the Department of Anesthesia. This is a talk about managing the unstable patient. It's a pretty quick and dirty talk that's based on you having some understanding of the basic pathophysiology and initial diagnosis of whatever shock state your patient might be in. Please see a talk with that title for a fuller description of that and to gain an understanding, because that's absolutely key. The goals of this talk are to go over how to select empiric vasoactive medications to stabilize a patient and how to manage respiratory distress in its earlier state, and deciding who to intubate and just how to stabilize respiratory status so you could buy time to get your thoughts together and figure out what to do next. There are other titles that I would encourage you to see for further depth on fluid management, fluid selection, vasopressors, and inotropes. Respiratory distress is not a single diagnosis, but a big, very broad term that encompasses a huge host of problems that include problems with elimination of CO2, assimilation of oxygen, aeration of the lungs, actually getting air into the lungs, airway issues, and maybe some neuromuscular problems as well. So taking care of these patients becomes very challenging because you have to have some understanding of what is acute and what's chronic and what's new. And in addition to getting a handle on all these as well, you want to have some sense of what their hemodynamic issues are and what's going on with the brain. And this could be, go in a couple different directions. It could be horribly depressed, it could be obtunded, or it could be in overt distress and just this fear of near death. And so your evaluation, whatever objective measurements you could figure out, respiratory rate, kind of look, listen, and feel, just take a look. Is there air actually getting through the neck? Is it getting into the lungs? What does the lung movement even look like? That will all give you a really good sense of what the problem is. And so you really want to kind of characterize it in terms of whether air is actually getting in and out of the lungs, if it's a unilateral problem, bilateral, focal, foreign body, something going on in the neck. Is all this distress resulting in CNS changes, or are CNS changes driving this? Same thing for hemodynamics. You can have someone who has got an altered mental status, who has terrible respiratory function, and it could be very well due to cardiogenic shock or just inadequate blood flow to the brain. So your tools here are really physical exam, looking at the patient. What does it look like? Just think about the whole respiratory system, from the respiratory centers, from consciousness on down to the diaphragm, with muscles and lung parenchyma thrown in between. And that would give you kind of the list of what you need to work on, and maybe some characterization of the problem. Kind of tied into all this too is what is the work of breathing. And obviously intertwined with all these is, what kind of therapies are going to give the best result to this patient. So let's talk about two different categories of breathing problems. The first let's dispose of, because unless you're a surgeon, an anesthesiologist, and someone who's used to managing very difficult airways, opening them up, getting tubes in, or even doing surgical access, this is going to land in somebody else's hands. And so what you really want to do is just temporize these patients if you can, just to make, to avoid you doing some kind of cricothyroidotomy if that's something that you've never done before in your life or scared to death to do. So what you're after here is just really, listen to the neck as if you're listening for bruits, and just listen for air entry. And if you see respiratory motion of the diaphragm and the muscles of the chest and everywhere else trying to get air in, and you don't hear any air, or it's like really high pitched, really kind of barely moving, the kind of a squealing sound, that patient has got some stridor, and it's an absolute emergency to open up the airway. So look for foreign objects if you can. The patient might be able to tell you whether there's an aspirated foreign object or not. And the immediate maneuver, in addition to calling for expert help, is to actually increase the pressure exerted on the oropharynx. So if you think of something like BiPAP or CPAP, that basically overpressurizes the upper airway in the oropharynx, such that, let's just say this is, let's say this is kind of a constriction of the airway. Lungs are down here. That when you have subatmospheric pressure here and you're trying to inhale air through here, that negative pressure down here is drawing these two, the two sides of this obstruction I've drawn together and basically closing off the airway. So if you can close this airway with a mask and pressurize this system here such that the obstructing structures are pushed away, you have a chance of getting some airflow in there, which will buy you time to do something more definitive. Whether you think this patient needs to be intubated, it might be very hard to actually get a tube through here, or whether a surgical airway is needed. But that's a very dire situation. A ambu bag is probably not your tool of choice here, because in fact those things have a lot of valves in them, and so the patient's now going to be not only drawing against 1 atmosphere of air, but against all the demand valves that are inherent to the structure of the ambu bag. If you can get your hands on a Jackson Reese and you know how to use it, those kind of ventilation systems work really well here in the right hands. BiPAP is probably going to be your friend. That's an easy one to ask for. It's an easy one for a respiratory therapist to finagle. And then medication-wise, anything that can help shrink tissues here, like racemic epi. Bronchodilators should be avoided here because those actually, due to their beta effects, might actually dilate some of the blood vessels in this area, and that might even make your obstruction smaller and your stridor worse. So hopefully this won't fall into your hands and require the management of it. Even in the most expert hands, this is very, very scary. So temporize if you can. Get that help in there that you need. Do your best. So lung injury, I'm kind of putting in the category of something going on with your lung parenchyma, and this could be blood, pus, water, pneumothorax, something below the neck that's causing you problems. Obviously, pneumothorax you could pick up hopefully by physical exam and take care of that on its own terms. But a lot of the patients that you see with respiratory distress turn out to be those that have some kind of infection in their lungs, whether it's unilateral, diffuse, or pulmonary edema due to heart function, or flash pulmonary edema, again, from some kind of cardiac event. But a lot of it will be primary lung insults. When you look at your patient, you want to really characterize the work of breathing and get a sense of, is it really a very high work of breathing, and is that something that the patient can sustain? Even someone with a completely normal blood gas who's breathing really, really fast, and it looks like they're laboring really hard to get air in and out, those patients will not last. So you have to really judge your support by clinical conditions more than absolute values of ABGs. The trends on those might help you, but really it's the appearance of the patient that's going to be kind of the key thing. In thinking about distress, I find it very convenient just to think about the pulmonary compliance curve, where you have delta P here and delta V here, and normally this is kind of what it looks like. and patients at end exhalation end up right there on that part of the curve. And so it takes very little delta P to get very big delta Vs. And so that's why we don't even think about our breathing. It's very, very easy. So contrast that with someone who's working their tail off to breathe and who has very rapid, shallow breathing. Quite likely they are going to be working down here where there's a lot of work being done, but not a whole lot of volume going in and out of that lung. And so you want to help that patient breathe. And this is actually where CPAP and BiPAP and non-invasive and invasive ventilation can help, because if you can support the patient with some kind of pressure support, either non-invasively or invasively, that pressure that's coming from the machine is replacing the delta P that they have to generate. And if it's a matter of muscle fatigue, just adding that pressure support non-invasively can actually really help them move through this part of the compliance curve and actually get back to decent gas exchange. So that's kind of the basis of where non-invasive ventilation comes in. Not only the pressure support, but the PEEP that you can dial in. And what PEEP is good for is actually helping maintaining recruitment of the lung. And so PEEP literally is a pressure that you dial in, so when the patient starts exhaling, it's kind of like this fence that they do not cross when you draw it. So if, let's say this is 8 centimeters of water PEEP, and I'm helping the patient with pressure support, and they're taking this breath, then when they exhale, it's a slightly different curve. Boom, they're right here, and this might be a better part of the compliance curve for that patient. So they're already starting out in a better place. If they're taking some spontaneous breaths, they will require less pressure support if it's a supported breath. And further, if you manage to open up any of their alveoli and their patient who's prone to early airway closure, you might actually prevent them from reaching that closing volume where they'll lose that alveolus and have even more of an interpulmonary shunt. So this is a kind of a depiction of where you can help rescue somebody with some form of non-invasive ventilation, and it basically kind of assumes that everything else is fine. So if the patient's absolutely obtunded, this will not work unless the patient's obtundation is totally because of hypercarbia. And if you watch the patient for 20 minutes while they get some better breathing and they can actually reduce their CO2 and regain some consciousness, yeah, that will help you there. But probably you're not going to be able to be very successful with this if you've got depressed levels of consciousness. If your problem's a hemodynamic problem, certainly you can support the patient using this kind of modality while supporting hemodynamics. The trade-offs are is you probably want to sit a patient up when you're working on ventilatory support. But the good news is that by having to use less diaphragmatic work, you're actually freeing up a lot of cardiac output for the rest of the body. And so you can improve oxygen delivery to the rest of the body by actually decreasing the work of breathing. People that are really huffing and puffing might have 25 or 30% of their blood flow going to the diaphragm just so they can stay alive, whereas normally it's like 5% or thereabouts. Pretty effortless. So again, you can open up some airways, prevent closure. So with hypoxemic respiratory failure, non-invasive support is a great temporizing measure, which sometimes can work, sometimes not. If you have increased alveolar fluid, such as with CHF, you can actually help the heart by decreasing the work of breathing, help the heart by improving oxygenation, help the heart by actually lightening up the load. So there are patients on a more favorable part of the compliance curve while you're diuresing the patient. And in fact, patients with heart failure that you manage properly with non-invasive, many do not require intubation, and in fact there's a mortality benefit by doing exactly that. Sometimes patients have just really low lung volumes from either intrinsic lung disease, blue bloaters kind of with smaller sizes, or sometimes you get the emphysematous patients who are working way up here in this part of the compliance curve. And again, their underlying anatomy is incredibly inefficient for breathing, and so the least amount of perturbation, say a bronchitis or a small pneumonia, can completely tip them over, so their work of breathing goes through the roof and is unsustainable, or just isn't efficient enough to get the job done. And again, just proper non-invasive support of these patients can sometimes buy time to get them out of a distressed state, to get some of the CO2 down, where you can work with them, make the work of breathing easier. So patients who don't fit into any of these categories, that look, there's a CNS problem, there's a hemodynamic problem, maybe you're about to start on an operative intervention, they look like, they're ready to die, and you can tell by their CO2 rising that just the work of breathing is too great for them. Those are the patients that require intubation, as well as those that just require so much oxygen that you can't supply it non-invasively, or an occasional cough or pause in breathing just cause desaturation. You're obviously into the long haul with those patients, and getting yourself organized to do tracheal intubation and subsequent mechanical ventilation is really the only way you can go on those patients. And again, you can temporize them a little bit. What do you do while you're getting all your intubation crew together and your supplies? You can definitely do non-invasive ventilation, but it probably will not lead to a long-term strategy that will help them keep off the vent. I think for respiratory problem, the lab values, CO2, O2, as well as work of breathing, that'll tell you whether you have time on your side. Do you have a crash situation that you have to intubate like yesterday, or are you starting just to get kind of trends that are in the wrong directions, and you can temporize that with non-invasive ventilation? You also want to know what's going on with their brain, their hemodynamics, and what are their other needs, are there other surgical needs, etc., because that will tell you whether you want to use non-invasive ventilation or cut to the chase and intubate. And also, within these different kinds of ventilation, is it probably primarily an oxygen problem where you really want to emphasize PEEP, or is it kind of a ventilation problem where you really want to think more about CO2 elimination? And also, is it a workload kind of problem where you would want to use pressure support to decrease the work of breathing? So I think this is enough information to help you take care of a lot of garden variety sick patients that come your way. Hope it was useful. Let me know if you have any additions or any feedback.